Welcome to Emergency Insights. I'm your host, James Carter. Today we are focusing on the common etiologies of leg pain and numbness, a high-frequency chief complaint across primary care, urgent care, and the emergency department. For the healthcare provider, a systematic approach to the differential diagnosis is essential to distinguish between benign structural issues and diagnoses demanding immediate high-acuity intervention. We will review 8 primary categories of causation, beginning with the common structural and neurological issues. First, spinal nerve compression or irritation, most commonly recognized as sciatica. This pathology involves inflammation or direct compression of a nerve in the leg or a nerve root in the spine, often leading to a unilateral pattern of pain and paresthesia. Closely related is spinal cord compression. This indicates a more severe, often central narrowing of the spinal canal, which typically results in pain and numbness with a bilateral distribution, raising the index of suspicion for myelopathy. Moving on to circulation, blood vessel conditions represent a critical, time-sensitive diagnosis. Leg pain and numbness here are indicative of decreased blood supply, which can stem from blocked arteries, warranting assessment for acute limb ischemia, or blocked veins, suggesting a deep venous thrombosis. Fourth on our list are pelvic and hip problems. Pain may be a referred symptom secondary to joint dysfunction in the hip or sacroiliac region. We must also consider irritation of associated nerves or conditions like piriformis syndrome, where spasm of the piriformis muscle compresses the underlying sciatic nerve. The next 2 categories require a meticulous history and laboratory investigation. Infection encompasses a broad range, including osteomyelitis, spondylodiscitis, Lyme disease, herpes zoster, or even HIV-associated neuropathies, all capable of producing acute or subacute lower extremity symptoms. This leads directly to systemic conditions. Metabolic disorders, most prominently poorly controlled diabetes leading to peripheral neuropathy, or endocrine imbalances such as hypothyroidism, can cause primary nerve and muscle damage manifesting as chronic leg pain or paresthesias. Finally, we address the diagnoses that constitute neurological emergencies. The 7th cause is the highly critical cauda equina syndrome. This diagnosis is marked by severe, often bilateral leg pain, numbness, and motor weakness due to significant compression of the nerve roots descending from the spinal cord. Recognition of saddle anesthesia and bladder dysfunction in this context necessitates immediate surgical consultation. The 8th category is tumors and cysts. Any space-occupying lesion or mass in the lower back or pelvis can generate leg pain and numbness by directly compressing a critical nerve or occluding a major blood vessel. These are often diagnosed after initial conservative treatments fail or when symptoms progress rapidly due to mass effect. Maintaining a broad and disciplined differential, particularly when evaluating new-onset neurological deficits or vascular signs, is the cornerstone of competent management for lower extremity pain in the acute care setting. That's all the time we have for today. Thank you for listening, and we'll see you next time.